Good morning, ladies and gentlemen. My PhD is about maxillofacial surgery in cleft lip and palate patients. I'm Alexander Schulze Wenning, medical doctor and currently a dentist and PhD student here at Semmelweis University. I want to increase healthcare accessibility for patients with cleft lip and palate by reducing invasiveness through research-based clinical decision-making. My two topics so far are, the first one is a comparison of basically two types of philosophies of surgery, comparing one-stage and two-stage palatoplasty by looking specifically at the maxillofacial and speech outcome for those patients. My second topic is a proof of concept meta-analysis investigating the clinical applicability of salivary microRNA as an early cancer diagnostic factor. As I mentioned to you before, the comparison of one-stage and two-stage palatoplasty. This is how far we are with our manuscript, and soon it will be sent to internal review. So, cleft lip and palate is the most common orofacial deformity with a worldwide incidence of roughly 1 in 6 to 700 live births. Much higher incidence in Southeast Asian countries. It results embryologically from a non-fusion. And as you can see, it is of uttermost importance to provide proper and the best treatment for those babies and young patients. Currently, there is no universal guideline, which is very well demonstrated by a Euro cleft survey, coming to the result that 201 different cleft teams operate in 194 different protocols. Those two philosophies, which I told you before, developed over the last century and are mainly the one-stage and two-stage palatoplasty. The one-stage palatoplasty can also be called the simultaneous palatoplasty because you're operating the soft and hard palate together in one operation. The assumed benefits of this are a better speech development. Contrary to this are the supporters of the two-stage palatoplasty, where the soft and hard palate are separately operated with variable degree of first hard or soft, so on. There we assume a better maxillofacial development, since earlier operation of the hard palate results in earlier scarring and inhibition of the maxilla development, and so may result in a hypoplastic maxilla. That's why we set out to investigate if patients benefit more from either one-stage or two-stage palatoplasty. And the patients we looked at were patients with uni- and bilateral cleft lip and palate. The intervention was one-stage palatoplasty and the comparator two-stage palatoplasty. We looked at primary outcomes cephalometry, so one main indicator for the maxillofacial development, hypernasality and audible nasal air leakage for speech development, anterior crossbite, and velopharyngeal insufficiency as secondary outcomes. Our hypothesis was that one-stage palatoplasty has the same or a better clinical outcome than two-stage palatoplasty. Because if we could show that one stage is at least as good or better, we could increase the amount of operative cases and also decrease the anesthesia exposure. And increasing the amount of operative cases is especially important in third world countries and developing countries, where not everybody has the ability to receive the surgery yet. This was our systematic search done in the 3 databases and the search key, as you can see. In the end, we ended up with 36 eligible articles. So the first plot I would like to show you is about the Umpp angle. The Umpp angle is a very important angle for the soft tissue morphology. It is the angle between your upper incisor and your palatal plane. An angle of roughly 110 is considered to be optimal, ±5. Anything less will result in a retrusive or more in a protrusive lip. Here we could show that there is a statistical significance supporting the one-stage surgery, also with this including a clinical significance. The second one is a velopharyngeal insufficiency. This one was measured as odds ratios either being present or not present. Velopharyngeal insufficiency is the velopharyngeal sufficiency would be the ability of your velum to properly close. And here we could also show that there's a statistical, with this also a clinical significance supporting a one-stage surgery. Audible nasal air leakage, the air which escapes through your nose while speaking, is a huge contributor to quality of speech. Also here, we did an odds ratio of either a frequent or a rare occurrence of audible nasal air leakage, and we could show a statistical significance, with this also clinical significance favoring as well the one-stage approach. Hypernasality, also an indicator for speech quality, also measured as an odds ratio for mild or severe occurrence of hypernasality, showed also that we have a clinical significance and clinical significance favoring the one-stage approach. In this case, there was no statistical significance, but in every study, we could see that the occurrence of a severe hypernasality was more common in a two-stage approach rather than a one-stage approach. The Selenasian A-point angle. It's a very crucial angle for the maxillofacial and skeletal shape of your face because it describes the angle between your base of the skull and the A-point, the most concave point of the maxilla. Also here we got gather the most data, so it's the strongest outcome we consider. An angle of 82 degrees is optimal, plus minus 2 degrees in this case as well. Anything less than 80 is a retrognatic maxilla, or more than 84 a prognatic maxilla, as you can see in these pictures. Here we did not show, we couldn't find a tendency favoring one method over the other, which is also an important outcome for us, since then a one-stage method could be done, or also next one, the sixth figure which I would like to show you is the Selenasian palate plane angle. So also the angle between your base of the skull to your palatal plane. Also here there was no tendency favoring one method over the other, with this also supporting rather the one-stage palatoplasty approach. The A and B angle, for most or for all of the dentists very well aware of, it's about the occlusion, and with the occlusion also very important for your maxillofacial appearance. Also here there was no tendency favoring the one-stage over the two-stage or two-stage over one-stage, with this also supporting the one-stage approach. For anterior crossbite was also measured as odds ratio, the same accounted. There was no tendency favoring one method over the other. As a conclusion, we might say that maxillofacial development does not differ substantially between one stage and two stage. It was only shown in the U1PP angle, as you remember, but the one-stage surgery provides better speech development. One-stage surgery is the operation of choice for most cases. It should still be said that every patient should be regarded separately, and we definitely need to do more studies on it, more studies comparing different timing, and what would be really good or important is also with a much more detailed cleft width description to really develop a proper protocol for which type of cleft, which width, where it's located, on how to operate it then. I mean, it's given the nature of the disease or the malformation, it's pretty difficult to conduct RCTs, but of course this would be great. Our strengths are that we had a strict accordance to the PRISMA guidelines, and up to date it's the most comprehensive study in this matter, and it's the only one comparing multiple outcome variables together. The other studies only look at either one type of speech or one type of maxillofacial development. We look at it together, and it's also the only one subgrouping the two-stage approach further. Our limitations are, unfortunately, there are no RCTs, it's only retro and prospective study design and very different operation techniques. My second topic, which I would like to present to you, is the investigation of clinical applicability of salivary microRNA as an early cancer diagnostic factor. So, cancer treatment has developed over the last decades so many folds, but still cancer is one of the leading causes of death. Why is this so? Because detection is still lagging behind. For many cancers, such as lung cancer or pancreatic cancer, the cancer is only found by accidental findings or when the cancer is symptomatic, and most often in this case, it's too late for a curative approach. That's why we need earlier detection. One might say, you could also argue with blood plasma microRNA, but to prove that salivary microRNA would be of so much benefit because we don't need any specialist to draw the blood, so it's much cheaper. There's absolutely no infection risk in salivary microRNA samples, no needle prick injuries for us as practitioners, and it's much more accessible, also for patients who are maybe just phobic of doctors and just don't want to go to hospitals in general. Last year's research has proven that salivary microRNA shows specific expression pattern for the tumor of the origin, so also with this enabling us to find the tumor of the tissue of origin of the tumor. Secondly, also research from last year has shown that microRNA is stable and abundantly found in saliva, and with this showing the feasibility and also feasibility of our study there. Our aim was to investigate the clinical applicability of salivary microRNA as an early, non-invasive tumor diagnostic marker. Our population were all patients with cancer. The intervention is salivary microRNA. As a comparator, we look at blood plasma microRNA And the outcomes we will look at is sensitivity and specificity. Our hypothesis is that saliva is as sensitive and as specific as blood plasma samples in early tumor diagnosis. With this, we could enable early targeted treatment with a much more accessible, with a higher accessibility, accessible basically for everyone. This was our systematic search done with this search key. Prospero is done. With this last words of Walt Disney, I would like to thank you and say, if you can dream it, you can do it. Thank you everyone for your attention.
In the first project on figure 6, if I remember well, before figure 7, there was the second group. Why is this group that kind of differ, and why the first one is in that way? So because you see the mean differences technically really differ in this case.
It's because the Fouday group looked at, compared to all of them, the Fouday group looked at a very, very different age when they checked the outcomes. So not only the type of operation contributes to the high heterogeneity, also the age at which they checked the outcomes. Some looked at the outcomes in the lateral salivary at 4 years, and in the Fouday group, they did it after 20 years. This one, and also the different type of surgery which they performed, led to this huge difference there.
Congratulations for your presentation. I just wanted to know which criteria did you use to observe clinical significance in your results? Thank you.
The clinical significance was mainly discussed with Professor Christian Nagy, who is one of the leading maxillofacial surgeons and special cleft palate surgeons here in Hungary and also in Belgium. And we discussed the statistical significance and then related to his clinical knowledge, how important this is, or if it relates as clinical significance.
My question connects to the last question. Have you already compared the protocols and data between your country and Hungary?
Between Germany
Yes.
and Hungary? No, we haven't. I mean, there is no specific German protocol or Hungarian protocol, which is also demonstrated, for example, that the maxillofacial department in Maria Utza is doing a one-stage approach, and the one in the pediatric clinic is doing a late two-stage approach. So there is not really a German protocol or a Hungarian protocol, as well as shown in the Eurocleft. 201 cleft teams operate 194 protocols, so there must be a much broader comparison done.